Hi, I'm Jay Resnick, and I'm an oral surgeon in beautiful Tarzana, California, which is in the Los Angeles area. And I'm here today to talk to you about my passion in oral surgery and implantology, which is the use of 3D imaging and computer-guided implant surgery to improve the accuracy and the success of tooth replacement. I was trained the way that most of us were trained about 20 years ago in residency, and I used for imaging a panoramic radiograph, and we had a little 25% magnification ruler that we used, and that's what we used in order to measure how much height of bone we had in order to determine what length of implant we were going to place. And then of course we determined the width of the implant essentially by the size of the tooth, a wide platform generally for a molar, a narrow diameter for a usually a lower incisor or an upper lateral incisor, and then somewhere in the middle for premolar teeth and canines. And then we might get study models to take a look at the patient's occlusion and decide where the implants were going to go. And if we decide to get really fancy, we might even get some study models and have the patient's restorative dentist do a wax up that we would use to indicate to us where the proposed final restoration was going to be, so that we could place our implants a little bit more accurately. And sometimes we actually use that surgical guide in surgery. Those techniques served us well, or served me well in my earlier years of practice. And here's a patient who came to see me. She was about a 75-year-old woman who had fallen at home and fractured teeth numbers 8 and 9, as you can see here. And they're basically not restorable. And so the plan is to remove both of these teeth and at the same time place immediate implants. And so we had a surgical guide made. We got study models, had a surgical guide made from wax ups where we have the channels through the pontics indicating the path of the long axis of the implant coming out in the cingulum area for these central incisors. And you can see on the right here that our post-op film, or actually this is our second stage film, when we place the provisional abutments, is that the implants are nice and parallel, they're nicely spaced, and that this is a nice aesthetic and functional result. And then we take a look at our second stage where we're placing our final abutments and provisional crowns, which we're going to give some time for the soft tissue to contour around these before the final restorations are made. And we've got some nice positioning, nice aesthetics, good tissue margins. Everything looks nice and healthy. And we would call this a nice result of placing immediate implants and now the final restoration, which was about to occur. And unfortunately, I didn't get final photos on this patient, but she did have a very nice result according to the GP. Another case here, we have a patient who comes to see me, and he's got quite a few implant-related and periodontal issues. We're going to be removing tooth number 2, as you can see here, and then tooth number 3 needs to be replaced with an implant. Teeth numbers 7, 8, and 9 are all periodontally failing and need to be removed and replaced with implants. And tooth number 10 has been missing for a couple of years, and the patient would like to remove or to replace that so that he can have an implant-supported bridge up front, or actually individual fixed anchored prostheses if possible. Also, we want to restore this down to the second molar on both sides, so we have implants planned at the number 18 and the number 31 sites. Well, as you can see here, this patient has a deep overbite, and we know that we're not going to restore, his dentist is not going to restore him in that overbite. He's going to level out the occlusal plane. So I asked the dentist, please send me some surgical guides, do a wax up, and let me know where those, especially those anterior maxillary teeth, are going to be post-restoratively, so I can place the implants in the right sites and in the right positions for him. So he said, gladly, I'll get the patient in, I'll do some wax ups, I'll make some surgical guides, sent the patient for surgery. Patient shows up for surgery, I open the boxes, and this is what I found. Just some vacuform shells of the patient's existing occlusion, which essentially were worthless for what I needed. So I did this case pretty much by eyeballing the whole thing. And I think all things considered, this is a pretty nice result. It looks like all the implants are well positioned. This number 31 implant's a little close to number 30, but luckily the tooth had already had a root canal, and it's now been about 10 years since I did this case, and still no issues in this area. And clinically, I would say this is a nice result. And these were all individual crowns that were placed, and restored back to the first molar up above, and then the second molar is down below. And I would call this a really nice clinical result. And so it's not that we can't place implants well by the traditional techniques. It's just that I've learned over the years that there are some issues with the way that we traditionally have done implant surgery. And that is that I've learned that clinical exam and then using study models and panoramic radiographs and periapicals can all be misleading of the patient's true clinical anatomy. How many times have you had a surgical guide available from a study model and you had the implant placement, the positioning all set through the center of the occlusal table of the pontic in the wax up or in the surgical guide, and you flap it open and you realize that you can't place the implant in that position, and so you need to move the implant generally a little bit more lingually or palatally in order to get the implant in good solid bone. The other thing is that two-dimensional imaging by itself can be very deceiving, and this is a good example of how two-dimensional imaging, non-radiographic, shows us this point. So here's three guys at the museum. They look like they're probably friends. They kind of looks like they kind of went together. They're all wearing coats. They must have all come in from the cold together to look at some dinosaur bones. And here, if we look at this two-dimensional image, we would think that the guy in the red jacket is being eaten by this T-Rex or whatever this is. And of course we know that this isn't true. This is just a kind of an optical illusion because we've got a two-dimensional image of a three-dimensional situation. And so unfortunately, if we were using this same type of information to determine, let's say, if there's some pathology or if this guy was really in trouble, we would be deceived. Same thing goes for using two-dimensional imaging for planning implants. So this is a patient who I saw actually right before I started doing CT imaging and guided implant surgery, before I had cone beam in my office. And as you can see here, I took out tooth number 31. I did ridge preservation grafting, and now the site's ready to have the implant placed. I took a wax pencil and I marked out basically the dimensions of the crown that was going to go there, the dimensions of the implant, and the location of the mandibular nerve. And it looks like if you measure this with your 25% magnification ruler, that there's plenty of room for at least a 13 millimeter implant. And so I then got a cone beam in my office and decided before I actually did the surgery that I was going to use 3D imaging for treatment planning this case. And sure enough, I'm glad that I did, because if you look at the cross-sectional image, you would see that even though it looks like from here to here is 15 millimeters, so from here to about here is at least 16.5 millimeters, that a 13 millimeter implant should be fine and be away from the nerve. If I'd placed a 13 millimeter implant, we would have had this situation here on the right where the implant would have perforated through the lingual cortex of the mandible. And when that occurs, if we're lucky, then the implant just sticks out through the lingual cortex, and maybe the patient will kind of play with it with their tongue for a while until they irritate the overlying mucosa. The mucosa breaks down, the implant gets infected. You take the implant out, you graft, and you start over again, and you put a shorter implant. That's if you're lucky. But if you're not lucky, you could hit the lingual nerve that passes in this fossa, and the patient could end up with a temporary or even a potentially permanent paresthesia or anesthesia of the tongue. If you're really not lucky, you can perforate the lingual artery, which also passes in this area. And of course, then you've got a major hemorrhage into the floor of the mouth. And there have been reported deaths occurring from airway obstruction when this has occurred in the dental office. And of course, we all want to avoid these kind of complications. And so, this is one of the pitfalls of two-dimensional imaging and planning implants, especially in this area of the mouth, but really anywhere, is that 2D just doesn't give you a full picture. The issues with traditional implant planning is that many times we would look on our two-dimensional images. We might have a surgical guide made that told us right where the center of the final prosthesis was going to be, the occlusal table, and we had our pilot drill through the pontic in the surgical guide. And when we flapped it open, we would see that the bone was not where we thought it was. It was a little bit more to the lingual or the palatal. And so we'd have to move our implant clinically in surgery to try to get this implant in good solid bone. And then the result was the restoration became an afterthought. And you talk to enough general dentists, restorative dentists, they commonly complain about seeing implants that were placed a little bit too far lingually or a little bit too far buccally, where they're really having a hard time restoring them. And wouldn't it be nice to be able to provide our referring dentists and our restorative dentists that we work with implants placed in the right place every time? So using a panoramic radiograph and model-based surgery is not always a guarantee of success. Just ask these patients and these dentists. You take a look at these images, and these are fortunately not my cases, but you can see that these are all cases where a surgical guide may have been used, two-dimensional imaging was definitely used, and implants were placed by some experienced surgeons, all of which are basically not restorable. I mean, these are not. This implant here is going to have to be taken out. You can see this one's probably a little bit too far to the facial. This implant's going to be a little difficult to restore. This one's going to be impossible. Here we see clinically, dentist will probably end up just burying this implant and not even using it, and just have a restoration on these three implants here, or maybe use this one. Probably most likely use that one. But again, this is a situation we'd like to avoid. This is another case, not done by me, but the patient had implants placed by flapless surgery using a surgical guide made off of a study model. And you can see that pretty much every one of these implants is placed too far to the facial, because the two-dimensional panoramic didn't tell us the three-dimensional width of the bone. Clinical exam was deceiving, and the surgical guide just messed us up. Now here's a case where I used a surgical guide. I had this patient come in, and we took out tooth number 31. Again, this was pre-cone beam in my office, and so I wanted to make sure that the implant was properly placed, because I knew that the distal root of number 30 went kind of distally, and so I made this surgical guide with a metal sleeve, guide sleeve, to make sure that my pilot drill was in just the right place at the right angulation, the right positioning, and all subsequent drills would follow in that path. And so I wouldn't have to worry about coming close to tooth number 30. Well, here's my post-op film, and even though I was as careful as I could be, and I'd had probably at least 10 years of experience under my belt when I did this case, tooth number 30 has been impaled by my implant at tooth number 31. I ended up having to take the implant out, do apical surgery on the first molar, and eventually grafted the site, and then placed another implant a little bit more distally. And in that case, we actually used 3D imaging to make sure that, and a guided surgical guide to make sure that the implant was properly placed. Another case, 49-year-old man comes to my office, and he's basically healthy, but he's got periodontal involvement of teeth numbers 12, 13, and 14. And so we look at his panoramic that we took in at the initial exam, and you can see the 12, 13, and 14 all need to go. And I told them we're going to need to build this bone up. We're going to have to do some grafting. We're going to have to do a sinus lift in order to place implants. And the patient, what he really wanted was to be able to have 3 individual implants so that he could floss between them like they were his own teeth. He didn't want to have a bridge. And so I told him that, with the grafting and sinus lift, we'd be able to accomplish that. And I guess between my fees and his restorative dentist fees, he decided to go somewhere else. And so we never saw him for surgery. Well, he shows up in the office probably about 6 months ago. And, he's got now a prosthesis in place. And it's you can see that it's a 3-unit bridge on 2 implants and looks aesthetic. It looks good. The soft tissue looks healthy. And I asked, why have you come to see me? And he said, I'm not happy. He said, you promised me that I would have 3 implants and I'd have 3 individual teeth. And I went to a board-certified oral surgeon and a board-certified prosthodontist. They did a CAT scan. The prosthodontist made a surgical guide for the oral surgeon. And I went to surgery, and when I woke up, the surgeon told me there was only room for 2 implants. He placed the first 2, and there wasn't room for the 3rd one. And I said, well, gosh, I don't know what to tell you. Let's get some radiographs. So we got a cone beam scan and looked at everything in 3D. And really, I would say, it's not the greatest result on the sinus lift, but the implant placement looks good. The angulation looks pretty good. I would say that this is a nice case. The surgery was well done. I know the surgeon, I know the prosthodontist, they both do good work. But this patient was extremely unhappy because he had been told that he was going to get, not only by myself, but by the surgeon who actually did the surgery, 3 individual implants and 3 individual crowns. And he was complaining of constantly having food trapped in this area and hygiene issues, and he was fed up with it. He pulls out of his pocket this photocopy of a radiograph saying, look, there's room for 1, 2, 3 implants in here. And I said, well, you might be right. So we did some planning on cone beam, and sure enough, with adequate spacing, these implants are about 3 millimeters apart, 3 millimeters from the adjacent teeth. We actually can get 3 implants in place, and they can be restored with individual crowns. Now, the patient really wants me to take out those 2 implants, bone graft, and start over. I don't really want to do that, but it just goes to show that even with a good clinical team, an experienced prosthodontist, experienced surgeon with 3D imaging and a model-based surgical guide, that implant placement can be less than accurate. And as you can see, the surgeon probably was going to place the first implant here, but it went off at an angle. He placed the second implant through his surgical guide. It also went parallel to the first at an angle, and of course there was no room for the third. And so this is the kind of thing that I would see and we would experience with traditional implant surgery. So it makes you think. Let's go back to why we place implants. The bottom line is we place implants to replace missing teeth. And of course, teeth are, I always tell patients in consultation, you've basically got a crown, which is the part that you see in the mouth, and you've got the root, which is what anchors the crown into the bone. And an implant is essentially the same thing. You've got a prosthetic crown, the implant is your prosthetic root, and of course you've got the abutment between the two. And so, when we are placing implants, we have to be aware of where we're putting them and how accurately we're placing them. How good are we at our implant surgery when we use model-based surgical guides or placing them freehand? Well, Overall, about 10 to 15% of the implants that are placed, and these statistics come from talking to a number of well-known surgeons and looking at the literature, about 10 to 15% of the time, the implant is not exactly where we had intended it to be. It may be off so little that it's still restorable, or it may be way off where it's not restorable at all. But overall, about 10 to 15% of the time, the implants are not where they were planned to be. And in the anterior aesthetic zone, which is even more critical where we place the implants, it's a little higher, about 20%. And, as good as we are, we need to do better. We need to get rid of this concept of surgically driven implant placement where the surgeon flaps it open and puts the implant where the bone is, and replace it with the concept of prosthetically driven implant placement. And of course, what we mean by that is that we start with the ideal prosthetic restoration. We start with our blueprint, as you can see here, and we work backwards from there to place the implant in the ideal site. And if the bone is not ideal, if there's not enough bone, if the soft tissue is not ideal, then we prepare the site with bone grafting, with soft tissue grafting to get them ready for ideal implant placement before we place that implant. Guided implant surgery takes 3D imaging one step further, where not only are we using 3D imaging to accurately evaluate the bony anatomy, but we're actually doing the treatment planning on the computer in 3D virtual reality, and then using that surgical data and uploading it to a site somewhere where a surgical guide, a very accurate surgical guide, is made from that three-dimensional data. So this is basically how it works. This is the system I have in my office is the Sirona Galileo. So I also have CEREC CAD CAM system. And what I'm able to do is I'm able to import my 3D optical scan of the patient's occlusion into my cone beam scan, and then also my proposed restoration. This is actually a digital Pontic that was made on CEREC, and import all this data into the scan for the purposes of implant planning. So now I'm going to go and I'm going to select my implant system that I'm going to use. It's going to be at site number 8. I'm going to use a BioHorizons. I'm going to use the tapered internal plus laser lock, 4.6 millimeter diameter, 12 millimeter length. Click OK, and then I drag and drop my implant into the site. And then with my mouse, I can adjust the position, the angulation, the depth, and the positioning of that implant so that it's lined up correctly and accurately with my final restoration. If it's going to be a crown or that's going to be cement retained, then generally we put the long axis of the implant along the incisal edge. If it's going to be a screw retained, then it's a little bit more lingual into the cingulum area of the tooth. And we can look at this in 3 dimensions. We can rotate our 3D skull around, scroll through it, and even see, we can put in our guide sleeve to make sure that there's enough room for the guide sleeve interproximally. So we're going to select our BioHorizons guided surgery system in this case. Click OK, and now you can see this is our guide sleeve, and we can make sure that there's enough room. Use that for fine-tuning our implant placement. And then we can print out a planning report that we can look at, which will show us multiple slices of the implant placement on screen. We can print this out. We can place it in the patient's chart. We can also PDF this and send it to the patient's dentist and make sure they're happy with the where the implant is going to be placed. And then the next step for ordering the surgical guide is very straightforward. We just go to another drop-down box, order the surgical guide, and we go through a number of steps. Here we're going to use our registered optical impression in order to create the surgical guide, and then we're going to let the guide manufacturers know which implant system, which guided implant system we're going to use. and click OK, next a few times. We have all our information there, which we then can prepare the data for transfer either on a CD or direct uploading, and makes the process very simple. It only really takes a couple minutes to create our surgical guide, and it's the guide sleeve in the surgical guide that really does the lion's share of the work. It basically directs the direction, the position, the angulation, and the depth of the implant placement. And then, of course, then we once we've done all this, then we can upload our order, print out a report that will go into the patient's chart, again saying our implant size and the surgical guide's been ordered, and then that goes off to the lab, and we get our surgical guide back. And the surgical guides that are used for guided implant surgery can be made a number of different ways. They can either be by milling from a solid block of acrylic, or they can be created de novo from a 3D printing process. But all the information comes from that 3D imaging, the combination of the CAD/CAM data and the cone beam data. And as I mentioned, the essential part of this whole process is that master sleeve, because that is what controls the position, the angulation, and the depth of each osteotomy. And when we're using a fully guided system as opposed to a partially guided system, it also controls the placement of that implant fixture. So here is what our surgical guide looks like, and you can see here the guide sleeve within that surgical guide. Here it is on the surgical model. We can actually use this in order to create a provisional prosthesis if we wanted to too. So here is now our post-op image that was used or that was taken on that patient after implant placement, and you can see here that the implant placement was just spot on perfect, and we're right in the middle of the ridge buccolingually, right where we need to be. This patient has an immediate provisional restoration, which you can see here, and the final abutment was actually placed at surgery, and we're in good solid bone parallel to the adjacent teeth. So this is ideal implant placement that was done very simply. The procedure, I think, took about 3 minutes to place the implant through a tissue punch technique because there's lots of keratinized tissue, and then the provisional restoration, which was pre-made, went on with almost no adjustment. My first guided implant surgery, though, was not quite so simple. This patient came to me with just basically a terminal dentition. I dentulated her, and she wanted to have a fixed prosthesis in the upper and lower arches, and had heard from her dentist about guided implant surgery. And I'd been thinking about taking a course in guided implant surgery. This was back in 2006 because I saw the technology as being the way of the future. And patient basically told me if I didn't take that course and do her surgery guided, she was going to go somewhere else. And so I basically looked for the first course that I could find, hopped on a plane, went away for the weekend, and came back and did my very first guided surgery case. It was a Nobel teeth in an hour, upper and lower case. Took me a little bit longer than an hour, but we did 8 implants on the maxilla, 8 implants on the mandible, placed an immediate prosthesis on each. And the surgery took, including prosthesis placement, a little over 2.5 hours. And this was a revelation that I could place 16 implants that accurately in 2.5 hours and have this type of accuracy. And this patient is now 8 years post-op, and I see her on a regular basis, and all these implants are still doing quite well. So guided implant surgery really allows us to provide our patients with the best treatment plan that we possibly can, because we're placing our implants accurately, precisely, and more importantly, consistently. That guide makes sure the implants go where they need to be every time, or let's say 99.9% of the time. Also, we're doing our treatment planning completely prosthetically driven. So we're not flapping the site open and placing the implant where the bone is. We're planting the prosthesis first and placing the implant where it needs to be for those final prostheses. And because the implants are placed more ideally in the bone at better angles, easier to restore, easier to maintain for the patient, hygiene's improved, we have really a higher success rate with guided implant surgery than we do with freehand implant placement. Also, the technology allows us to place implants immediately and place provisionals immediately, because we can see at consultation whether we're going to have enough bony anchorage for primary stability when we place the implant or not, and whether or not there's enough stability, or we think there's going to be enough stability to place an immediate provisional. So here is a patient that comes to my office. He has got tooth number 8 here, as you can see, has a fistula, it's got bone loss, it's got a periapical radiolucency, periapical lesion, it's had endo, it's had apical surgery, and this tooth is basically failing. There's lots of healthy apical bone to engage, and so we're going to treatment plan this case with guided implant surgery, and we're going to use the planning software to decide where the implant needs to be placed for the final prosthesis and whether or not we can place an immediate provisional. And as you can see here, with a 15 millimeter implant at this site, and I'm not sure why this says 11, but anyway, we've got a 15 millimeter implant in good solid bone, at least half of the implants in solid bone, if not more. So we know that this is a case where we can do an immediate prosthesis. It's going to have enough anchorage that we're going to be able to be successful. And I always tell my patients that when we're doing an immediate prosthesis, that the tooth is a party tooth. It's there only for looks. It's not there for function. And if there's any doubt in their mind that they can stay on a softer diet and stay away from that tooth for at least 6 weeks, they get a flipper or an Essex bridge. Also, we always make an Essex bridge as a backup to have at surgery, just in case I place the implant and it feels not quite as solid as I would like it to be. We've always got that backup ready to go, and so the patient doesn't have to leave missing their front tooth. Using our surgical guide with the sleeve in it, the master sleeve, we can use components from the implant manufacturer to actually set an analog into our master model and create a master model with an analog, and this is what's used to create the immediate provisional restoration that is placed at surgery that requires essentially no adjustment. And so here we are removing tooth number 8 in this patient. You can see that there is a periapical granuloma or soft tissue lesion attached to it. We're going to curette out this socket very thoroughly. I do everything under magnification and headlight so I can see exactly what's down there. Make sure that we clean out the socket very thoroughly. You can start to appreciate that they're right under here or right there. There's a fistula with a soft tissue and a bony defect that we're going to deal with. We've cleaned out the socket real well. We've irrigated it. It's been thoroughly debrided. Place our surgical guide, place our throat pack, and now through our master sleeve with our drill guides, we're now going to, with very light pressure and lots of irrigation, prep our initial pilot drill, our 2-0 twist. We then immediately go to our next drill. We don't have to stop and take radiographs to make sure that our drill is properly placed because we've done all the planning work ahead of time. So it's basically really boom, boom, boom. First drill, second drill, third drill, and now our final drill, through our final drill guide, we're placing or doing our final osteotomy. In this case, it's a 3.7 millimeter diameter osteotomy for a 4 millimeter implant. And then the implant itself goes through the surgical guide, and on the surgical guide, or attached to the implant, is this guided mount that also goes through the surgical guide, and that guided mount controls the position, the angulation, and also the depth of placement of that implant. So we know that the implant goes just to the right spot. Generally, I'll stop about a half a millimeter short of being fully seated and complete the seating and adjust the timing of the implant with a hand torque wrench. We're now going to take off the implant mount. We take out our surgical guide, which now we can see our implant here, which is in good solid bone. I'm going to place a cover screw over the top of the implant temporarily. You can see here the defect, which we are going to now fill in with some collagen tape. It's going to be doubled over and essentially stuffed into that defect between the periosteum, which I've elevated off of the bone, and the buccal alveolar bone. And then we're going to pack some freeze-dried mineralized bone into the area. We're going to basically fill in the defect on the facial. We're going to trim our collagen tape here so that it doesn't overhang. We're going to finish compacting our graft and then clean it up a little bit and then take off our cover screw. And now we're ready to place our immediate prosthesis, which has been prepared in the lab off of the master model. And what you'll see is this prosthesis goes into place basically with no adjustment. It goes right into place. We've got the proper timing of the implant, the proper depth of the implant. So this provisional restoration goes right in, and basically then we just tighten down put in the abutment screw, tighten it down to 20 Newton centimeters. So we do it by hand first, and then with the torque driver handpiece. And as you can see that this tooth is a little short, we're going to take it a little bit more out of occlusion because we don't want this tooth to have any occlusion on it at all. Very light interproximal contact. And post-operatively, you can see that again we have very accurate implant placement. This implant is perfectly placed. You can actually even see here where we grafted the bone on the buccal defect. And to do this type of immediate implant placement in the anterior, even with experience sometimes can be very difficult. That drill can skip off of the bone and become misdirected, and the implant may not end up where we want it to be. But in this case, we have perfect implant placement. This is our follow-up post-op at 2 weeks. You can see that our collagen membrane kind of poking through, that it's starting to break down. At about 4 weeks, the collagen membrane has broken down further. It's starting to epithelialize over. And then this is the patient's final restoration about 4 months post-placement. And you can see that the soft tissue defect has filled in completely. We have good mucosal contours, good mucosal health, great aesthetics. The lab even made this patient's permanent tooth on tooth number 8 look like same staining as the rest of his teeth. So the patient was extremely happy with this result. It's now been a couple of years since this case, and we've got good maintenance of bone levels, and the patient's doing a good job with hygiene and no problems at all. So one thing that I get asked all the time is, do you really need guided surgery? Do you need all this technology for simple implant cases? And my question to you is, how do you define a simple case? What is a simple case? In my mind, there is no simple case, because even if you take the straightforward case where you've got, let's say tooth number 30, and you've got a nice wide ridge, you've got healthy tooth in front, healthy tooth behind, your placement with that implant has to be absolutely spot on perfect. Okay, can't be too far mesial, can't be too far distal, can't be buccal, can't be lingual. It's got to be absolutely perfect. If you're doing multiple units, you actually have a little bit more leeway, and if you're doing a fully edentulous case, even more. So I think there's no such thing as a simple case, and I think for these so-called simple cases, guided surgery is even more essential than it is for some of the bigger cases. This is sort of the typical case that we do. A 62-year-old gentleman with some medical issues, diabetes, hypertension, tooth number 30, has a fracture. You can see the furcal radiolucency. He had a previous endo that was failing. You can see the a big pocket on the distal that goes all the way down to where the post ends, basically. So we took this tooth out, and I grafted it with some Mineros and Cytoplast, waited 4 months, and this is with Mineros, freeze-dried mineralized bone. And at 4 months, now we're going to do our implant planning. We've got our CAD/CAM image of the patient's quadrant along with the proposed restoration. We import that into our cone beam scan and use this for our implant planning. And as you can see in this post-op, and I don't generally do post-op scans on every patient, just when basically if it's a little more tricky case, or we want to make sure the implant's in just the right spot. You can see that we again have very ideal, perfect implant placement in this patient, and this was a slam dunk restoration for the patient's dentist. We put on a stock abutment at second stage, and the restoration just is absolutely perfect. This patient has no problem cleaning underneath there. It's got good contours. Aesthetically, it looks great. Functionally, it looks great. And years later, we still have good bone levels. In fact, you can see here the bone level actually rose a little bit above the collar of the implant. Now here's a little more complicated case where 3D imaging and guided surgery really came in handy. This patient was losing tooth number 15, which was the distal abutment for a bridge. He also had some atrophy of the posterior mandible and wanted some implants there. And you can see here's the atrophic posterior mandible on both sides. Here is where the dentist sectioned the bridge, and we took out the bridge, and here's number 15 that needs to be removed. So we're going to do our 3D imaging a little bit with a kind of a hybrid of the older and newer techniques. So my feeling is, for a complicated case like this, you can do CAD/CAM imaging, but really nothing is better than a traditional old wax up that's done in the lab to make sure that everything is in occlusion and fits together well on the study models, and that way we can plan exactly where these the final prostheses are going to go. And so then what we do is we take these models, these wax ups, and we duplicate them in stone, either in scannable stone, or in this case it was plain old regular yellow stone, where I did some sprayed with some titanium oxide or dioxide to make this more scannable. We take that scan of the study model with the wax ups, and we then import that into our cone beam, and we're going to use this now for planning where these 3 maxillary implants and the implants on the mandible are going to go. And as you can see in the maxilla, the ridge is a little narrow here, so we're going to be planning for a little bit of ridge expansion at the time of implant placement. And on the lower, we're going to do 3 implants on the right, 3 implants on the left, and on the lower right side, we're going to need to just augment a little bit of bone on the buccal at the time the implants are placed, and actually do the same on the left side too. So our plan in this patient is to extract tooth number 15 and then do a left maxillary ridge split to widen the ridge and place implants at 12, 13, and 14, and then place the implants in the mandible, 3 on the right, 3 on the left, and do some freeze-dried bone grafting on the facial in a few of the sites. This is the patient's immediate post-op panoramic, and on the pano, it looks like this is a little close. Clinically, it actually wasn't that close. You can see that he had some implants done in the past. So we've got our 3 implants on the upper left, 3 implants on the lower left, and 3 implants on the lower right. We allow those to integrate for 4 months. And this is the patient's post-restoration, post-final restoration panoramic, and his clinical photograph. And you can see here, this doesn't look so great, but of course these are the implants that were placed many years ago. These are the implants that were placed just 4 months before, here, and up here on the upper left. And this patient, as you can imagine, was just ecstatic about this, and even more ecstatic was the patient's dentist, who said this was probably one of the easiest implant cases he's ever done. And we've done, I can't tell you how many more we've done since then. Well, if you're like most surgeons, you are thinking the thing that a lot of surgeons think, and that is, I've been doing implants for over 20 years or over 10 years or over 15 years, whatever it may be, and I'm pretty good at it. Why do I need to learn a new way of doing implant surgery? And my first part of the answer is that time goes on, progress, technology improves. Are you still taking out impactions with a mallet and chisel, or do you use a high-speed handpiece? Are you using a paper scheduler and ledger in your office, or are you all computerized? Are you using straight pentothal for anesthesia? No, you're using a balanced technique with propofol. And would you even think of doing sedation or general anesthetic without a pulse oximeter anymore? No. These are all changes in the way techniques that we were used, protocols that were used since a lot of us trained, that have made treatment safer, more efficient, more successful. Are you still using one of these? Okay. This is the cell phone, or the type of cell phone that I first had when I got my first cell phone. I don't think any of us are using one of those anymore. We all have our iPhones and our smartphones. Technology improves. Okay? We have to improve our treatment of our patients as technology improves, because this technology allows us to treat our patients better. There are a number of guided implant surgery systems on the market, and so whatever implant system that you're used to using, there is probably a fully guided or a partially guided kit that goes along with that surgical system. Now, I was involved in the development of the BioHorizons guided implant kit, which was released on the market earlier this year. And I did that with the experience of having used many of the other implant systems out there, other guided implant systems out there, and keeping a mental note of what I liked and what I didn't like. And I used that information to design this surgical kit and to advise as far as what components should be in there and the clinical protocol. And we introduced this new surgical kit at the BioHorizons Global Symposium in Miami earlier this year with quite a bit of fanfare. And this is the surgical kit that we developed. And we really think it's a nice surgical kit. I think it's really one of the better kits out there now, not just because I designed it, but because of the fact that I used my knowledge and experience with other kits to help design this. We tried to make the surgical kit and the instrumentation be as simple as possible. It was designed to be used with the BioHorizons tapered internal and tapered internal plus family of implants. And what's nice is that the implants are all color-coded from osteotomy all through implant placement. So the narrow diameter, the 3.0s are gray, 3.8s are yellow, 4.6s are green, and the 5.8 is blue. And so not only are the implants color-coded, but so are all the instruments. So our master cylinders are color-coded appropriately, our drill guides, our drivers, and we have, because with the tapered plus, we have it's platform switched. We have a driver that's different than the tapered internal driver because it basically the implant itself has a smaller platform. This is the complete surgical kit, all the components, and so we have all of the drills, we have all of the drill guides. One thing that's nice is this quick connect, where we have two of these quick connect handles in the kit, and my surgical staff, the assistants, place the drill guides into both ends of the quick connect handle, and it gives us good control over the drill guides, and at the same time reduces the number of components that are in the kit. We also have tissue punches that are designed to go through the surgical guides, through the drill sleeves, Our implant drivers, the typical ratchet, hand wrench, and then if you're doing a fully edentulous case or a case with some large edentulous spaces where you're using fixation pins, skeletal fixation pins, those are actually 3 of them are included in the kit. And then the other thing here is this depth stop handle, and I'll show you how that is used. So here is our protocol. We've got basically for the 3.0 implant system, we just have 2 drills. For the 4.6, you're using 5, and for the 5.8 diameter, that goes up to 7 drills used altogether, although we're tending to skip a couple of the drills in the middle of the office, and it's working out quite well. You can see on the implant driver, we've got a number of position slots here on the driver, and that is where the depth handle comes in handy, depth stop, which I'll show you. So this is a tapered internal platform 4.6 millimeter implant. This is the green guide sleeve that's used because it's a 4.6 millimeter implant with a platform shift. And we start off with our 2.0 twist drill being placed into the master sleeve on the surgical guide, and then the 2.0 twist drill is used, and we do all our drilling with light pressure and copious irrigation. Then we go to the 2.5 twist drill, then the 3.2 twist drill, the 3.7, and then the 4.1. Then for placing the implants, we use our drivers, and they're all, of course, color-coded to the appropriate implant diameter and platform. So what we did on this implant driver is it's got 4 different depth positions. So you can see here 1, 2 below and 2 above this black line. And when you do your when you plan your surgery, you get an implant report that will tell you what drills need to be used for each osteotomy, as well as which stop position is used for each site. So here, this is at the second stop position. We have not only the stop handle, which can be placed into these grooves, or a disposable depth stop, which a lot of people like because it frees up one of your hands. Here is the depth stop in use. You can see how it will stop the drill guide or the implant mount, implant driver at the appropriate depth, and place the implant at just the right depth. So here's a case where we're using the system. This patient is a now 22-year-old female who came in to see me. She initially saw me get her wisdom teeth out, but also was having some issues with tooth number 10, which was failing. So you can see there's the tooth has had a root canal, there's a periapical radiolucency, and this tooth basically was diagnosed with a fracture after her wisdom teeth were out, and we planned to remove this tooth and place an immediate implant. So of course we're going to use the planning software to see if this is going to be feasible. So here you can see that we've got lots of good healthy bone in order to anchor this implant. You can see in the different cross sections we've got good solid bone buccally and lingually, at least 2 millimeters on the buccal, 2 millimeters on the lingual or palatal. We've got enough space interproximally, and we can line this up, the long axis of the implant, very nicely with the provisional or with the final prosthesis. So this is that drilling protocol report that I was talking about, and what it tells us is that the implant we're going to place is a 3.8 millimeter diameter implant that's 15 millimeters in length. And what we're going to be drilling is we're going to be using, through the drill guides, we're going to use the yellow drill guides, and we're going to drill a 2.0, 2.8, and 3.2 using the 28 millimeter long drill. And so the drills are of various lengths, and it's the combination of the position of that guide sleeve with the length of the drill that determines the depth to which the osteotomies are placed and to which the implant is placed. So here again is our master sleeve in our surgical guide. We're going to use our 2-0 twist through the yellow drill guide. And again, we're going to do this with copious irrigation and short strokes with lots of irrigation. Then the 2.5 millimeter guide and twist drill, followed then by the 3.2. And then the implant's going to be placed at stop position 4, and actually that would be right here on the drill guide. In this illustration, we're at stop position 2, but in this patient we're going to be using stop position 4. And let's take a look at the surgery. And this is basically in real time. So we're going to place our surgical guide, and this was a milled surgical guide, completely digitally made from all the digital data. We're going to place our throat pack, and we're going to use a tissue punch. In this case, the patient has lots of keratinized tissue, and so we have determined that we are able to use a tissue punch. So after we've used the tissue punch, we're going to use our little straight curette in order to remove that tissue plug that we've cut. So that comes out fairly easily. Sometimes we do have to remove the surgical guide in order to get it out. But now that we've got it out, we're going to do our initial osteotomy. We're going to place our 2-0 twist drill guide, and you can see it's in that quick connect handle. And we've got our 2-0 drill in place. Once it's in the guide, we're going to start the motor, and with light strokes, in and out pumping motion, so we are sure to get the bone fragments out and irrigation in, we've completed the first osteotomy. Then we're going to slow down the drill, and we're going to do our second twist drill, which is the 2.5. We've got our drill guide in place, and again, with copious irrigation and short light strokes, we're going to slowly advance the drill to the apex all the way down to the bottom of the osteotomy. And again, we're going to irrigate it, get out any bone fragments, and then go to our third and final osteotomy, which is using the 3.2 millimeter twist drill. And again, we're going to slow down the motor to about 200 RPM for this. And again, with light strokes, lots of irrigation, we're going to go all the way to the stop on the drill. So it's a 28 millimeter drill, and the stop on the master sleeve, master cylinder, determines how far that drill is going to go. We can see our osteotomies. We're going to, in this case, we take the surgical guide out to thoroughly irrigate. Surgical guide goes back in now, and then we're going to place our implant. Now, this patient was going off to college, and we had talked about doing immediate provisional for her, and discussed the fact that that provisional would be a party tooth. She didn't think that she was going to be able to maintain a soft diet, and so in this case we're just going to place the implant, place a cover screw, and then she's going to be having an Essex bridge as a provisional restoration. So the surgical guide comes out. We can look at our implant in place. We see that it's perfectly positioned at the ideal depth. We're going to now adjust the final timing with our torque wrench and final depth of placement, so that we're about 2 to 3 millimeters subgingival, right at the bony crest. Take our implant driver out. We're checking with a perio probe. We're just at about 3 millimeters there. Lots of irrigation, make sure there's no bony or soft tissue debris, and then we're placing a healing abutment that we're going to tighten down to about 20 Newton centimeters. So that's going to be placed. In this case, we didn't have to do any bone grafting when we took the tooth out, and the case is essentially done. And now we're going to put in her Essex bridge, which she's going to wear for the treatment period. And you can see that gives her a nice aesthetic provisional restoration. And this is our post-op image, which again shows very good, really perfect implant placement. and perfect spacing. And at her 3.5 month post-op check, we can see we've got nice soft tissue contours. Our healing abutment, remember this is about a 3 millimeter healing abutment, so our implant margin is basically 3 millimeters subgingival. We've got papillas that are developing in the site, and she is now off to college and back east, and she's having the restorative work done back in New York City, and so I'm hoping to get her final images back soon. So, I've been talking about guided implant surgery and guided implant surgical kits, and the question again comes up: do I really need this? Okay, and I liken guided implant surgery and 3D imaging to GPS. I call it's like GPS for placing implants. Okay, I can get from my house to the office, and I can get from my house to the airport without GPS. I don't really need it. And so, you may think, well, you can place a simple, straightforward implant or multiple implants without this technology. But I will tell you that my idea of this technology changed when I got my new car that had GPS with real-time traffic. And what I've found is that I can plug in where I'm going, and it will tell me what the traffic is like on the way to where I'm going. And so if I need to get off and take another route to get to the office or the airport more efficiently and not get stuck in that, it does that for me. The GPS with real-time traffic is like guided implant surgery. I can get along just fine without it. Okay? But I can get to where I'm going with greater accuracy, greater efficiency, and less stress using this technology. Well, that about wraps things up. I want to thank you for your attention, and I especially want to thank the folks at Dental XP for allowing me the privilege of sharing my enthusiasm for guided implant surgery and 3D imaging with you. If you have any questions or comments, feel free to email me at jresnick@sccofs.com, and I look forward to hearing from you. Thanks again for the time that you took out of your busy day to listen to me talk, and take care.